Thank you, sir, and good morning, everyone. Good morning, respected chairpersons, the faculties, and the delegates. It's an absolute honor, and I thank the organizers and the chairperson for inviting for the talk. Now, my topic has been made both easy and difficult by the previous speakers. So, let's move on with it. Okay, so I have no conflict of interest, none to declare as of now for this year. So let's start straight away with what's the lumbar canal stenosis is. Lumbar canal stenosis is basically narrowing of the lumbar vertebra in the central canal or in the lateral recess or the foramen. These are the three areas where you can have a stenosis which can lead to symptoms. And there is a diagram, pointers here, anyways. So you can see the central area, the foramen, and the lateral recess. So it is at these three preliminary locations that you can have a stenosis which will lead to symptoms. So central canal stenosis actually compresses the thecal sac and it bilateral spinal segments. It may produce bilateral symptoms. Lateral recesses and foramen stenosis generally tend to have unilateral symptoms because they compress the roots unilaterally. And generally the central canal stenosis arises because either of a disc bulge or a ligament hypertrophy or both. So lateral recess stenosis, it occurs from facet arthropathy, from osteophyte formation, compressing the nerve roots before it comes out of the foramen. It has so now what is actually, when we see the MRI reports, lot of pain physicians, lot of physicians as such get the reports from the MRI, which mentions the dimensions of the lumbar canal. So what do you mean by lumbar canal? As per a radiological report, sagittal diameter of 12 mm is generally considered as narrow as relative stenosis. However, less than 10 mm is generally considered as a severe stenosis, and most of the symptomatic patients have a canal diameter which is less than 10 mm, and that you can easily see on the report. This term was this terminology and everything was termed way back by Verviest. Also, when we see a patient, generally we tend to see some amount of X-rays films of the patient, some amount of listhesis. So what is actually listhesis? A sagittal plane translation of more than 4.5 mm or 15% of the anterior posterior is suggestive of some amount of instability of the spine. In terms of cross-sectional areas, more than 100 mm square at the respective area is considered normal, 76 to 100 is considered mildly stenotic, and of course, less than 76 mm square is considered severely stenotic. Now, before I get into the management and the algorithms, some commonly used terms that all the physicians and the surgeons get, like what's an annular tear? So annular tear is actually basic because we have a central nucleus pulposus and you have an annulus surrounding it. And most of the patients in the early phases come with an annular tear. So you can easily identify as a T2 or a stir hyperintense signal. So this is the hyperintense signal that you have, right? So this is commonly seen in the T2 MRIs, or you can have a stir MRIs, which basically fat suppress T2. So these are the sequences that you see for an annular tear, and these are the patients who you need to take utmost care. I'll come to it in detail stage. Now, what we commonly use: disc herniation, protrusion, extrusion, migration. These are the terms we commonly use. A disc herniation is basically a protrusion of a disc metal, roughly 25% of the disc circumference, and it is beyond the limits of the intervertebral disc. So it's a contained disc, or it may be uncontained disc. So now this is just a diagrammatic representation of where actually you get the disc herniations. It can have a medial or a central. You can have paramedian. The paramedian is the most common, by the way. You can have foraminal stenosis, and very rarely you can have extraforaminal stenosis, which is irritating the roots and which compresses which produces irritative symptoms. Now, these are a few pictures with a diagonal representation. We can have an extrusion with a cranal migration with lumbar canal stenosis, and generally, the level of PIVT and the symptoms do not match in the subscript patients because there is a herniated segment going up and compressing the nerve roots at that zone. So you need to be very, very cautious while handling these patients, even for a surgical trajectory point of view. When you're planning an endoscopic or even a microscopic, there is some relevance for that, which is beyond the scope of the current discussion. So this is so when you use that there is an extrusion with cranial migration, it is connected to the primary disc. So this is called as an extrusion, and it has gone up. So this you can easily appreciate from this part. So this is the herniated disc. It has gone up. And if you see at the respective section, there is a severe canal stenosis here, producing a lumbar canal stenosis in this junction. So we also see the paracentral protrusion, which has also, gone caudal. So it can either go cranial, it can go caudal, and this can produce different types of symptoms based on the nerve roots or the level of thecal sac. There is a compression. So this is This is again, if you see in the corresponding sections of the MRI, this is the parent disc, and there is a disc migration which has gone caudally. So you need to be very careful of this subset of patients because the symptom level may actually differ in these patients. Now this is again a term which is called as a disc sequestration. Sequestration is used when the fragment is completely detached from the primary disc, and these also produces symptoms based on the level whether fragment has migrated. So these are all, the confusing pictures. Now commonly you use a term which is called as ligamentum flavum hypertrophy. What's that actually? So there are studies, and normally if you see that if the ligament flavum is normally more than 4 mm, we consider that it is hypertrophied. So as I've already said, lumbar canal stenosis can be because of a disc bulge or ligamentum hypertrophy, or it can be a combination of both. So if the benchmark is 4.4 mm as per the study by Park, but you generally consider as 4 mm. Now there are some arrow marks here, right? So we have talked about facets by the previous speakers. So please have a look at the facets in the stir sequences. If there is a hyperintensity and you have enlargement of the facets, consider the facet may be a potential source of pain generation. So again, the symptoms have been clearly discussed. Low backache, the most troubling features. You can have radicular pain, you can have sensory loss, you can have motor deficit, you can have bladder bowel disturbance in a graded manner. And the differentials commonly that we see are vascular in case of claudication, in peripheral artery diseases, degenerative OA of hip and OA of knee, peripheral neuropathy, especially in the diabetics and other patients, inflammatory, arachnoiditis, sarcoidosis, neoplasm, commonly interdural extramedullary tumors mimic lumbar canal stenosis due to degenerative disease, and a tethered cord syndrome. Also, you can get similar features, but again, you have to have in mind the spectrum of the diseases that you need to you need to have in mind before going for diagnosis of a degenerative spine disease completely. So normally what happens is that the common symptoms are intermittent neuronal claudication or radicular pain. Let me say that if a patient has a single level paracentral disc irritating one nerve root, you will get radiculopathy in one dermatome. However, in elderly patients, obese patients, you have multiple level of stenosis. The more common presentation is a claudication, which consists of pain or tingling or numbness sensation in the gluteus, buttocks, or in the anterior part of the thigh, and is aggravated by walking few distance. So that's basically what a radiculopathy and what a claudication is. Now, chronic back pain, we have used it very commonly, and normally the symptoms last more than 3 months. That is called as a chronic back pain. At any moment of time, 12% of the global population will have, will have low back pain, and females generally tend to have more common. So this is the demography basically of it. And as previous speakers said, 95% of the patients, up to 95% of the patients recover after acute backache. So I'll come to the algorithm straight away. Now, what is the diagnosis? So I have been given the, the topic to throw light on the diagnosis and an algorithm, how to approach a case of back pain. So commonly radiological investigations that you do is an X-ray lumbosacral spine, lateral inflexion and extension, and nowadays we are asking for a standing X-rays to know about the posture of the patient. As previous speakers told, the posture is very important. So the pathology may appear on one segment, but actually it is the posture that is responsible for the herniation. So you need to be very, very cautious, and you should approach regarding the posture of the patient. We also get can you go back? Yeah. So we also advise the commonly used test that has been done by physicians and surgeons worldwide is the MRI spine. CT in few cases where you're suspecting some past fracture or need to do some interventions. And we routinely prescribe an inflammatory marker, ESR and CRP, just to rule out an infection before you think in the line of degenerative diseases. So this I borrowed it from our human textbook neurosurgery, which we commonly follow, and this is something we generally follow. So history is very, very important. Any backache is not about one specific branch. It is about a holistic approach to a patient, and history is very, very important. Duration, location, aggravating factors, what are the relieving factors? You have to examine, and as ma'am has presented, the posture, the alignment of the patient, whether there is a listing, whether there is some amount of leg discrepancy, the various tests, that needs to be done. Rule out the causes, then we look at the location of the pain, whether it's a leg, whether it's the gluteal region, whether it's the flank, paraspinal muscles, midline muscles. So when the patient's pain is aggravated by standing, walking, and straight lie test, whether it is aggravated by these tests, then you have to get an MRI done. So in the MRI, you can get a diagnosis of radiculopathy. So again, the history, the examination is very, very important before you move to a diagnosis. There are other differentials, which is again too cumbersome, but for the sake of it has been mentioned in the slide. So please make it sure that you always have a look at the posture of the patient, the BMI of the patient. So this is a holistic approach which of late the spine surgeons have been starting to take. So again, I have said the probability test is the elastic test which is commonly done, and our previous speakers have also described few tests to rule out other causes like a piriformis syndrome. So please do those tests before confirming that you are dealing with a degenerative spine producing the symptoms. Now, what is the criteria? When do you do an imaging for a low back pain? So there is the American College of Radiology which has clearly outlined the criteria or appropriateness for doing imaging. So if there is an initial backache, which is uncomplicated, it means there is no red flag signs, there is no deficits, there is no blood disturbances. Imaging is generally not considered necessary. So if it's the first patient that comes to you, simple backache, you can straight away send the patients with medications. There is no need to do for any long list of investigations. However, there are a subset of patients like patients who are having a history of trauma, patients who are known osteoporotic, patients who are on steroids, patients who have, initially you can get an imaging done with an AP and lateral X-rays, that's it. Rule out some gross pathology, say gross listhesis, before sending the patient home on medications. However, if the cutoff period which is recommended is 6 weeks, if after 6 weeks of failed considered management or patients exhibiting red flags in between, so before sending a patient with medications, do explain the red flags. New onset deficits, bladder bowel issues, new onset weakness, those are the red flags as far as the spine surgeon is concerned. So in those cases, please get a scan earlier. Red flag signs I've already discussed, especially new onset deficits, bladder bowel dysfunction, anesthesia or the saddle anesthesia, or if patient is having a history of fever or any trauma or serious medical conditions. These are the red flag signs as far as we are concerned. So in these cases, we mandatorily get a scan done. So as I have already said, and we have presented the images, MRI is the preferred modality of the imaging. T1, T2 is the routine sequences. STAR sequences, what is a STAR sequence? It's a short tau inversion recovery sequence. It's basically a T2 with a fat suppression. So if you're looking for, say, sprained ligaments, you're looking for facet arthropathies in which you need to see fluids, please look at the STAR images. So MRI findings we have already discussed. So I'll move to the next slide. So again, before we move on to the other aspects of it, one important part is the facet effusion. Normally, as we have said, we have no imaging way of knowing whether the facet is the cause of pain, right, or the facet is unstable. So if you look at the STAR sequences, a facet effusion of 1.5 mm are likely predictive of a degenerative listhesis at that point. So the normal MRI you get is a supine MRI. It is not in the axial loading, right? So at times you tend to miss the, the imbalance or the listhesis. So please look at the facet joints, especially the STAR and the TT sequences. Facet effusion of more than 1.5 mm, which I've already showed in the previous slide, is suggestive of a listhesis. And if there's a clinically measurable effusion of more than 1 mm, it suggests that need to have a standing X-rays and further dynamic X-rays. So this is one example where you can clearly see that the MRI looks absolutely normal, but if you see there is a facet effusion around 6.8 mm. So this is a case of listhesis. So you need to work up properly for that. So this is a picture demonstration of that. So the duration critical is 6 weeks. If the patient is incapacitating pain or red flag symptoms, get an MRI. Otherwise, you can manage the patient with the imaging for 6 months. If the patient has significant deficits, patient is having red flag signs, patient has to go for surgery. Otherwise, you can give a waiting period for the patient. Now, again, this is a meta-analysis, surgical operate versus non-operative patients. Based on that, there's a low quality evidence which suggests the surgical treatment is more superior compared to conservative. Why low quality? Because of the inherent weaknesses of the individual studies incorporated in this meta-analysis. So epidural steroids, someone is asking, epidural steroids is strict no till 6 weeks. Unless the patient is so incapacitated that he is not able to do daily active living, epidural steroids is a strict no till 6 weeks. It's after 6 weeks that we generally give the option, okay, the radiculopathy is not, the disc bulge is not severe for a surgery, you can still try for a epidural steroid, and meanwhile go for weight reduction and posture muscle strengthening exercises. So this is the advice that we generally give. And as previous speakers have said, epidural steroids generally last for 6 months and max for a year. And please do not go for repeated epidural steroids at the same level. It can lead to epidural fibrosis, which complicates our surgery in the next time. So what is the selection for surgery? These are the guiding principles for surgery. Patient should be symptomatic. That's point one. The symptoms must correspond to the imaging level. The symptoms should be refractory to the conservative and medical management for 5 to 8 weeks. Cutoff generally take it as 6 weeks. There should be reasonable expectation that surgery will improve the functional outcome for the patient, and the degree of expectation of the improvement should be commensurate with the risk of the patient. These are the 5 guiding principles when we offer someone a surgery. Immediate surgery when patient has cardiac arrest syndrome, and preferably should be done with 48 hours. I'll be concluding it. So it's a classification of listhesis, because that is also a major cause of stenosis, but it's way beyond our topic. And of course, fusion. Please do not go for fusion for symptomatic discs. Even for grade 1 listhesis, please do not go for fusion. Fusion has myriad of side effects. As someone said, multifidus is major muscle of your body, which gives strength to your spine, and generally the surgeons tend to disrupt the multifidus during surgery. So surgery should be given, the advice of surgery should be given only when all measures fail. Surgical options, we do a varied options. We do microdiscectomy, we do transfemoral surgeries, we do uniportal and biportal surgeries, we do missed lift. So there are various methods of operating depending on the patient's symptoms. And case-based scenarios, I'll just wind up. 24-year-old patient with OPD with the complaints, radiating pain since the last week, no preceding trauma, fever. Patient is carrying on studies and able to sit for 3 to 4 hours for his studies. The weight is 90 kilos. Again, this is very important. No motor neuron deficit, no sensory deficit. So if this is the MRI, what should be the best option? So the duration is 2 weeks, so definitely not steroids. Minimally invasive surgery, absolutely no. So this is the best option: weight reduction, back strengthening exercises, attention to posture, and medications for pain relief. That is when we are sending to a physiotherapy, please do talk about the posture to your physiotherapist. Tell the physiotherapist to document what muscles are taut, what is the gait, and what is the posture. That should be documented from a physiotherapist in the next follow-up. The same patient visited after 6 weeks, still complete of a backache, unable to sit for more than an hour at a stretch, now no new deficits. What are the options? So in this case, the best option will be, the best options will be epidural steroids and anesthetic, which still advise for weight reduction. Now, if the patient has a violent cough and then came with a URI and violent cough, and now comes with numbness and weakness of the foot and has to strain for the urine. So this is a cardiac arrest syndrome for the patient. In this case, straight away you have to go for admit, obtain a fresh MRI, and take for urgent surgery. So this is an evolution of a patient, a hypothetical patient, which I have put in the mind how to tackle the patient. So I'll just skip the patient because of lack of time. So take-home messages: lumbar canal stenosis is an ever-growing problem. It has immense psychological and financial implications for our society in India, where the patient is both aging and getting obese. 6-week conservative therapy is advised in patients with new onset backache without red flag signs. Dynamic X-ray, MRI with T1, T2, star images, and GRE are available for evaluation. Red flag signs for cardiac arrest syndrome. And patient with 6 weeks failed trial of conservative therapy can be considered surgery when the reasonable expectations that the surgery will improve the outcome or the functional outcome of the patients, and the risk are less as compared to the benefits. Thank you. Thank you so much.